All right, folks, welcome. December, we're back. I'm not on honeymoon, unfortunately. I'm no longer in Hawaii. I'm not bitter about it. I just need everybody to send me $10 so I can buy the $2 million condo that I rented. It's alan.fredendall@gmail.com is my PayPal. It's the same for Venmo. Okay, so if you haven't been here before or you're watching the recording and you haven't sat through this before, the premise is we're looking at a fitness athlete, somebody that's a CrossFitter, Olympic weightlifter, power lifter, bodybuilder, sometimes endurance athletes, runners, cyclists, triathletes, Iron men, Iron women, that sort of thing. We'll talk about the initial evaluation, symptom behavior, initial treatment, trial response, and then talk about whatever loading we did in the HEP and kind of follow the person throughout their entire course of care. 99% of the time, these are patients who have finished their plan of care. This is probably the 1% of the time that is not true. Mainly because the last visit for this patient was supposed to be yesterday and he had to reschedule to tomorrow. So theoretically he will be done tomorrow, but we'll see. So this patient is call him TG, 39-year-old male, CrossFitter, about 4-year history. Actually started CrossFit within a couple of days of me starting CrossFit, so I know him very well. In addition to doing CrossFit, he is a lacrosse coach at a facility in town. So he is very active for work. He's teaching people lacrosse. He's running a couple higher level competitive high school teams that kind of the whole premise is to get them into college and get them scholarships. So he's working with really high level lacrosse athletes. He still plays lacrosse himself. He plays basketball. So very, very active dude. Previous PT history, dealing with some really bad shoulder pain after he began CrossFit. About a year after he began CrossFit, that we got him through. I actually worked with Mitch, my business partner, on that. Got back to muscle ups and handstand push-ups and snatching and kind of all the aggravating stuff that comes with a labrum injury. So shoulder's doing well. He is coming in this time for some back pain. So started with me back at the beginning of September, looking at symptom behavior from the top. Pain 2 at best to 6 at worst, right? Kind of that band we're used to seeing described around L4, L5. Has radiculopathy down the left leg, backside of the leg, very sharp as it crosses the knee into the calf, and has some foot tingling at times. So pretty progressed radiculopathy. He has dealt with this for 9 months before he tried PT. Ag factors for him, pretty much anything that involves the spine, handstand push-ups, overhead lifting, deadlifting, squatting, running, jumping. And then day to day, when he's not playing lacrosse or coaching lacrosse, he runs those lacrosse programs. So he goes back and forth between very, very active and then sitting a lot at the computer, doing a lot of the back end logistics stuff for the organization that he runs. So for him, that looks like symptoms come on after sitting more than 10 minutes and very similar driving more than 10 minutes. So he's sitting a lot for work. He's driving far and often to go to lacrosse games and stuff across the state and in neighboring states. His only easing factor that's really anything that relieves his pain is standing up. So if he can stand for a couple minutes, his pain comes down to that 2 out of 10. So all things considered, severity and irritability are low to moderate here. And then if we look at any history related to this, he has been seeing a chiropractor since this started in January. So he's been seeing a chiro 2 to 3 times a week for almost 9 months with, unfortunately, no change in symptoms. So he's getting spinal manipulation, he's getting heat, he's getting e-stim, but no long-term change in his symptoms. It's the same now as it was 9 months ago. He has a Theragun at home, which kind of helps the low back stiffness and pain short-term, but doesn't do anything, and has already gone at the recommendation of the chiropractor at this point before starting PT to have an MRI. Got an MRI, did not really have a follow-up with the ordering physician. just knows that he got an email with a PDF that said he had something with a bulge disc somewhere. So not too hung up on his image, which is great, but still has kind of already fell into the medical industrial complex at this point. Really long history of lifestyle behavior issues. I knew a lot of this before we did his eval, just from knowing him and working out with him for a couple of years. Does not sleep well, 1 to 2 hours of sleep a night, is very, very high stressed with his job, keeps his phone on all night long. If he gets an email at 1 a.m., it wakes him up and he answers it. He's got kids emailing him and stuff about scholarships and stuff like that, and is just not a person that can turn his brain off and have an off mode for sleep. And then he can get really down and depressed. He's a person that expects to PR every time we text a max or test a benchmark. And when he doesn't get that new PR, he tends to stress eat, tends to pile on the candy, the cereal, the ice cream, the pizza, all the kind of comfort food that maybe makes us feel better mentally, but does not make us feel better physically. And then alongside not sleeping well, really huge amount of caffeine, cranking a pot of coffee in the morning when he wakes up, drinking energy drinks throughout the day, going between being on the computer and driving and coaching lacrosse, and then always drops some pre-workout before taking CrossFit class in the afternoon. So definitely probably clearing 1,000 milligrams a day of caffeine. So getting into our hypothesis list, lumbar radiculopathy is obviously right on the top. Maybe the hip is involved, but these are very low, whether it's coming from the hip joint itself or the muscle around the hip. With a patient like this, where the symptoms are going all the way down to the foot and the foot is numb, we're not really thinking that could be associated with glute referral, but it's just kind of on the back of our mind, especially if nothing shakes out in the lumbar exam. So getting into a lumbar exam, we didn't really have to go very far. Bend forward for me, 50 degrees. This is a person that has exceptional mobility everywhere. This is the person you see hitting a clean or a snatch on Instagram and you go, geez, I hope one day I look like that. That's how this guy looks when he lifts. So exceptional mobility. So it's really weird for him to have limited mobility anywhere. So that lumbar flexion, only 50 degrees before symptoms reproduced, asking him to bend forward a couple times, peripheralize the symptoms and increase them, looking the other way into extension, stiff 17 degrees, and then asking him to do repeated extension did not centralize symptoms. So this is that rare person that kind of shows up in that McKenzie progression that does have a directional preference, but does not centralize. So clearly does not like flexion. Extension is not aggravating, but extension doesn't centralize the symptoms either. So this is a patient where this happens, you go, oh shit, like they would be awesome if he extended a bunch and it got his radiculopathy better, but unfortunately was not the case with this patient. Digging deeper into the exam, left quadrant, reproduced pain in the low back, the left glute, and radiculopathy all the way down the left lower extremity into the foot. And then looking at some neurodynamics, 50 degrees of straight leg raise with symptom reproduction, the higher up we got. And then prone PA exam, pretty much down his entire spine. Anywhere I pushed on it, we reproduced that left lower extremity radiculopathy. So at this point, fairly confident the symptoms are coming from his back. So we proceeded to trial treatment. We did some dry needling. We hit the whole spine, just blew the paraspinals apart, and we traced the left sciatic nerve down through the glute into the hamstring and calf as well. Using 2 Hertz, that's kind of the preferred setting and parameter for treating nerve issues, which is why we chose it over the alternating sweeping frequencies. And then for him, just wanted to retest, did we have an impact on that straight leg raise? And we did. We increased straight leg raise about 13 degrees, still symptom reproducing and painful, and able to increase his forward flexion to normal to 90 degrees, although it was still symptomatic. So for him, this is a person that is incredibly active. So this is not somebody that we're thinking about testing a deadlift max or anything, especially given his symptom behavior. Really want to focus on neurodynamics with him and just getting some motion into that spine. So giving him a 12-minute EMOM. The mindset here is this is something he can do at home. He has a little bit of a home gym. He's got a squat rack and a barbell and some bands and dumbbells and kettlebells. So wanted to give him some stuff that he could do at home. So gave him a 12-minute EMOM. a modified slump nerve floss, whereas he's bringing his head up, he's also lifting his toe up. So taking slack on in one spot as we're bringing tension on in another. So kind of a typical slider progression. A minute of banded cat camels, 30 seconds of banded planks, and then showing him how to give himself some self-traction with the band for that left leg. And then telling him to do this, like, hey, you can do this every day. You can do this a couple times a day, especially if you're really flared up, or you're about to do a lot of your aggravating factors. If you're about to sit at the computer for a couple hours, if you're about to get in the car for a couple hours, then please hammer this before then. It's going to make it feel better to be sitting if you can do this before, or even take a break and do this in the middle of long periods of sitting. We also talked a lot about lifestyle. We talked a lot about his volume of activity and his lack of recovery and the mismatch that's going on here, and that we have to chase better sleep. So we talked a lot about sleep hygiene. We talked a lot about maybe the caffeine keeps you awake, yes, but it also keeps you awake at night as well. We have to really get more sleep, especially if you want to keep doing CrossFit every day, you keep wanting to play lacrosse a couple hours a day, playing basketball a few nights a week. If we're going to be encountering that level of volume, we have to match it with recovery. And then I had him download Headspace on his phone and just told him to try Headspace out before bed every night. And we're just trying to chase, if not more quality or more quantity, than more quality. Although this is a patient where I don't normally push hours of sleep. This is a patient that I did because he's literally not getting any. 1 to 2 hours is nothing. So trying to really focus on sleep here, and then we'll address nutrition later on. So that was the eval. Now getting into the follow-ups, coming back visit 2. This is a cash pay patient that doesn't have insurance. So his frequency early on in this plan of care was about once a week, and then it backed off to every 2 to 3 weeks. So comes in the next week, visit 2. No real change, anything subjective, still stiff. Says I didn't really perform what you gave me. Did have some better sleep, reduced caffeine intake, so was able to get 2 nights of 6 to 7 hours, and then about 5 nights of 1 to 2 hours. So better, but not great. Straight leg raise showed some between session change here, 10 degrees with a straight leg raise. The lumbar flexion was still stiff and painful, although a little bit better than eval. And the extension was a little bit better, 7 degrees better, although he still said it was stiff, but I would call 20 degrees normal enough. Manual therapy here, some manual lumbar traction. I got out the Mo belt and had him in supine and hook lying. And we did some on-off traction there for 5 minutes. That improved his straight leg raise a couple of degrees. And then we did the same dry needling that we did the previous session. So 15 minutes at 2 hertz, paraspinals, glute, hamstring, calf, tracing the sciatic nerve and pinning it. And that improved the straight leg raise further to 66 degrees. So out in the gym now, trying to get load into the spine in a way that doesn't aggravate it. So deadlifts are aggravating, squats are aggravating. So trying to find stuff he can tolerate that's going to load up his spine and his paraspinals. So we have 20 seconds of a Sorensen hold. So the same position that we test people in, face down on the GHD, holding that reverse plank. Was only able to give me 20 seconds, which is fine, but very challenging for this patient. We got, after some barbell hip thrusts to load up the low back and glutes, was able to do 4x8 at 155, and then some bird dog rows to load up the back and the core. Was able to actually go pretty heavy here with a 35-pound kettlebell. So he did 4 rounds of that in the clinic with me. I told him to continue the previous HEP every day, multiple times a day. And then I wanted him to run through this 4 rounds at least twice a week after class. So block out 20 minutes or so after class twice a week and run back through these 4 rounds. Come back in a week. Let's see where you're at. Coming back to visit 3 a week later, really no change again in that resting pain, but noticing less pain during and after CrossFit workouts. Did notice or did do his daily HEP every single day at home, but only did the 4 rounds that we just talked about once. Noticing a lot better sleep, 5 to 7 nights now of 5 or more hours. Has stopped taking pre-workout before CrossFit, which is great. Says he doesn't really notice a difference in energy level working out, but that definitely it's improving his sleep. And now he no longer has pain with jumping. So he's able to do double unders and box jumps in class without pain. And he doesn't really notice low back pain or any of the left leg symptoms when he's playing basketball. Reassessing straight leg raise, 63 degrees, a couple more degrees than the last visit. Lumbar flexion has improved a lot. It's no longer painful. He's got 80 degrees now. So still a little bit stiff for this athlete, but a lot better than it was. And then no change again in extension. So now getting a little bit more aggressive with our dry needling, doing that 620 hertz sweep, the alternating frequency there. We use that protocol for muscle activation. Same thing, lumbar paraspinals, pinning the sciatic nerve down the leg, able to improve his straight leg raise quite significantly here to 70 degrees, which is what we would call normal for a straight leg raise. Although for him, still aggravating, still has a grimace on his face as we're doing it. So still in the moment reproduces symptoms, but the neuromobility there is quite improved. So getting a little bit more aggressive, introducing some deadlifts and reverse hypers out in the gym, having him do a 15-minute EMOM, 12 reverse hypers minute 1 at 30 pounds. Louis Simmons would say the reverse hyper cures back pain. So that's a device that I think a lot more clinics should have that are often in the back of a gym and never get used. And then some suitcase deadlifts, so some single-sided deadlifts. We have farmer's handles here. So doing 8 single-sided deadlifts on one side and then carrying it down the floor and back with 115 pounds. And then minute 3 doing the same thing, but on the other side. So just getting some unilateral load into that spine and a little bit more diligent load into the spine in general with this EMOM. Didn't really change his HEP here. It just said, hey, try to really hit what we talked about last time, the Sorensen holds, the hip thrusts, the bird dog rows. Try to hit that stuff at least twice a week and then keep up with your daily program. Visit 4, coming in saying, I don't really notice any pain at rest now. I'm still stiff when I wake up, still noticing less pain during and after CrossFit class. Performed all of his HEP at home and in the gym as I prescribed. Sleep is still continuing to get better, which is awesome. Sleeping about 7 hours a night. He said the biggest change he noticed is that this was still back in the fall, so he actually turned the air conditioner at night to cool down his house. Driving is a lot better. He's able to drive 90 minutes each way to a lacrosse game and didn't have pain. Although coming in straight leg raise was 40 degrees, which was quite limited from the last visit. Manual therapy didn't change anything from last time. That same dry needling protocol, able to bump that straight leg raise back to 63 degrees. And then out in the gym, loading 16-minute EMOM, minute 1, 15 hamstring curls on the rower. I love those for posterior chain. Get your butt right up against the rower, put your heels up on the rower seat, bridge, slide the rower seat all the way out to a straight leg, and then slowly curl it back in. That will smoke your hamstrings, glutes, low back very nicely. Minute 2, some more reverse hypers. Minute 3, some GHD Russian twists. And then minute 4 here, just working on neuromobility, having him prop his feet up on a slant board and then slowly do a Jefferson curl down with a kettlebell. Really great to work calf mobility, posterior chain, neuromobility, hamstring mobility, just really nice. Take the ankles out of the equation. We can really hammer the posterior chain with a slant board Jefferson curl. He loved those. Those are really great for flexible people as well that can hinge over and not feel a stretch in a normal Jefferson curl. So taking some slack up through the ankle can make even really bendy people feel a nice stretch there. Retested his straight leg raise after doing that EMOM. He's able to get to 75 degrees. So recommendation here, continue the current HEP. It seems to be working. Keep working on your sleep, keep working on the caffeine, keep doing everything you've been doing because we're making really good progress here. So coming back in, visit 5, again, no real pain at rest since the last visit. Noticing not as stiff waking up in the morning, actually able to PR a clean complex. We had been doing a cycle of at the time. I think it was 1 power, 1 hang power, 1 squat, 1 hang squat or something like that. So able to set a PR for that complex from when we started the cycle, which again, for him, very important. A person that expects to PR every time we test something. So he was happy to be able to set a PR again. Said he did everything I told him to do, just like I told him how to do it. Sleep still getting better, sleeping 7 or more hours a night. Not really noticing driving bothering him at all anymore. Straight leg raise coming in 57 degrees. Not as good as it was leaving last visit, but better than it was entering. Here, doing some manual traction, improve that straight leg raise a little bit. And then again, some dry needling, improve that straight leg raise a little bit more, back to 64 degrees. Out into the gym, really focusing on the Jefferson curl, because that seemed to help him last time. So having him do Jefferson curl off the steps. Just some hip work here, working on that hip stiffness. So some psoas marches with a TheraBand, some banded side steps, some banded monster walks, and then having him do this program at home as soon as he wakes up. So his biggest complaint now is morning hip and low back stiffness. So giving him this protocol, because he can do it at home as his HEP. Hey, when you wake up, run through this really quick. It might take you 5 to 10 minutes, and then go about your day and see how your hip stiffness feels. At this point, doing pretty well. So we bumped his frequency down to every other week and kind of cut him loose on his own to do his HEP for 2 weeks. So somebody I see and coach pretty much daily in the gym. So it's not like I wasn't going to see him for 2 weeks. I just said, hey, if something doesn't feel right in class, flag me down when you see me in the gym, or grab me before or after class. So cutting him down to 2-week visits. Coming back in, visit 6, no pain at rest. Stiffness has improved a lot with the new home program. He's been doing it every morning, still doing everything else I gave him. Has been working basketball back in over the past 2 weeks, able to go and play basketball for a couple hours a night, 2 nights each week. Sleep still getting better, saying that he has pretty much cut out all sugar from his diet. He can't remember the last time he had cereal, candy, pop. This is a person, I didn't know there's anybody left that drank full calorie pop, but this person is one of them, which is quite amazing, considering he's in such good shape. Straight leg raise, a little bit better than last visit, 64 degrees coming in cold, which is great. Almost normal without warming up, which is right where we want to be. Dry needling, straight leg raise went up to 71 degrees. Didn't get to load this week. He had to bounce early to catch a work meeting. And before he left, I said, hey, I just want you to focus on a couple things. Keep doing your HEP. I want you to focus on getting 100 ounces of water a day. Energy drinks, pop, coffee do not count. 100 ounces of actual water. Focus on eating your body weight in protein each day. For him, that's 180 grams. And I want you to get at least 1 large serving of green leafy vegetables for lunch and for dinner. So we had a conversation of what counts as a green leafy vegetable. And he was quite disappointed to learn what those things were, but he committed to adding those in at lunch and dinner each day, and then follow up again in 2 weeks. So getting near the end here, visit 7, no pain at rest. Stiffness is still better. Noticing a little bit of left anterior hip stiffness, that's new. Sleep continue to get better. Now saying I think I sleep at least 8 hours a night. Straight leg raise coming in cold, 68 degrees, almost normal. For him, not much to work on. We put him in prone, did some cupping along his paraspinals and had him doing prone press ups as he was in frog pose. And we were doing that prone anterior hip mobilization where the knee is off the table on a stool. That actually improved his straight leg raise to 73 degrees and it made his left hip feel better. So 2 for 1 there. Following up on that with, again, stuff he can do at home, some banded frog pose at home. You can do this a number of different ways. You can have the band pull the hip and distract laterally. You can have the band posterior and gliding the hip posterior as they're in frog pose. None of those are right or wrong. They're all going to tackle hip stiffness the same way. And then progressing his nerve slider a little bit, having him lay on his back, heavy band over the foot, going straight up and down, pumping the ankle. So we're kind of intentionally adding tension to the nerve now, going straight up like he's in a straight leg raise, also going out into external rotation, abduction, and then crossing the midline into adduction and internal rotation. So getting really aggressive now with the nerve slider, and for him just kind of seeing what that changes over time. So fast forward 2 weeks, coming in, I'm not stiff. I haven't had any pain. I'm just kind of sore from working out. I'm sleeping 8 hours or more a night. straight leg raise coming in cold, 75 degrees, 100% normal. So at this point, I'm thinking we're close to the end. I don't know that you need to see me anymore. It sounds like you're doing pretty well. It's only been 2 weeks though since you've been symptom free, so I don't want to just cut you loose. I want you to follow up. We'll block an appointment in 2 weeks where I'll text you and see how you're doing. You kind of give me the answers to all the questions that I normally ask you when you come into the office. Continue this home program. Don't just stop because you're feeling better. Keep at it. And continue definitely focusing on sleep, diet, protein. So visit 9, again, 2 weeks later, no pain, no stiffness, just sore, able to PRs clean and jerk, sleeping 8 or more hours a night, straight leg raise, 75 degrees, normal. So at this point, I said, it's been a month. I think we're through the woods. So at this point, we're going to call it done. And I thought we were done, but what happened was I went on honeymoon and came back. And as soon as I walked in the gym, he said, "Oh, thank God you're back, dude. I am so messed up." And so had him come back in for an appointment. My low back stiffness is back. My hip stiffness is back. That pain down my leg is back. By the way, both my knees hurt and my right calf, especially where it attaches to my ankle, is super sore. So I'm thinking, man, you were in a really good spot, a whole month of no symptoms. Like, what's going on here? So we unpacked kind of what happened. And so this was last week. I saw him on Thursday. Last Monday, he had come to Open Gym and tried to hang with the coaches who train competitive CrossFit, about 3 hours of training around lunchtime. So he did about an hour of Olympic weightlifting. He did cleans, he did clean deadlifts, he did push jerk, he did back squat. I think it was like find a 2-rep max of like 4 or 5 different lifts and then do some back offsets. It was a really hellacious Metcon. And then later that evening went and played 3 hours of basketball. So a ton of volume, literally 5 hours of exercise in a day. And then that night he said, "Oh, I only slept like 2 hours that night. I woke up Tuesday and I was totally wrecked. And I've felt painful, stiff, sore ever since then. I've only been sleeping 2 hours a night for the past couple of days." So had a conversation of, again, it's not that your volume is too much. It's that your volume is up here and your recovery is down here. And we need to close that gap somehow. It's easy to close that gap with reducing that volume, but I don't want you to feel like you have to. So what do we have to do? We have to up our recovery. We have to go back to sleeping 8 hours a night. Whatever's happening, if you're stressed, you're back on caffeine, whatever it is, get back off of it. Get back to where we were because you were able to tolerate this volume when you're getting 8 hours of sleep a night. So again, we had that conversation of acute to chronic workload ratio and the importance of recovery if we're going to try to hang with this amount of volume. Manual therapy wise, manual lumbar traction, that prone frog pose, hip mobilization, got that straight leg raise back from 52 degrees back up to 73 degrees. And then loading, trying to just address a bunch of the stuff that's going on, the hip stiffness, the knee pain, the calf soreness, telling him, I don't know if this calf issue is something that's been lingering that is now coming out because we're playing so much basketball, or if it's just related to playing a bunch of basketball and not sleeping well. But I want you to add some tempo calf raises in, keep those tendons nice and strong if we're going to be playing a bunch of basketball. Same thing with the knees, Pelican squat. Actually, Tommy taught me this back in August. Elevate your heel. A dumbbell is probably the easiest way for most of us to get it done, but elevate your heel high. And then you're basically just doing a quarter squat, almost like you're about to try a pistol squat. When your opposite leg is straight and your heel touches the ground, you're done with the lift. So really just intentionally overloading patellofemoral complex, quad tendon, patella tendon, having them do 4 sets of 15 per side, and then some more of that banded frog pose. So that was last Thursday. He was supposed to come in yesterday. So was hoping to have an awesome slam dunk conclusion for you all that went awry. But I'll definitely post the update when he comes in tomorrow for his check-in. I'm hoping sleep is back under control. I've seen him in the gym this week and he looks like he's doing well. He hasn't texted me. So I'm assuming he'll tell me tomorrow that everything is going well, and that hopefully we are for real discharged. But that was this case. So I'm happy to take any questions anybody has about anything we talked about. Tommy, you look perplexed.
I'm just thinking.
Okay.
I've always got a lot going. So you found initial exam, you found a lot of, or you reproduced back pain and leg pain, TLJ, upper lumbar spine. Did you ever hit the TLJ?
No. And I thought about that when I was writing this up the past couple of days of there's probably a lot of value there that I assumed the chiropractor was getting after and not addressing, but I could be wrong. I don't know specifically what techniques the chiropractor used. My mind initially went to, okay, we've had 9 months. We've had 12 times 9. What is that? 90, 108 visits of chiropractic care this year, and we're not any better. So if we were getting manipulation, was not the technique to go with. I think that if I had not seen the first 3 visits, there was really no change, but there was also no HEP performance. I think that if I had seen no change like that and him being diligent with his HEP, I would have gone back and reassessed. Is there something I missed? Should we try TLJ manipulation or lumbar manipulation, both? But because he got better without addressing it, I didn't go back to it. But I think if he had not progressed like I wanted him to, I would have gone back and looked into that.
Yeah,
that's definitely on my mind, especially that initial exam, that prone PA right there. I would not have expected that to produce his radiculopathy pattern. I would expect that out of the lower lumbar spine.
Right. Yeah, that almost even popped into my head when he came back however many visits down the line with the anterior hip stiffness.
Yep. And that was his complaint longer than the back pain and the leg symptoms was the left anterior hip stiffness. So there's probably definitely a component to that. And I think since I get to see him tomorrow, I've had time to reflect on that. Even if he's feeling great tomorrow, I'm probably going to hit him anyways and just have him keep track of how his hip feels over the next couple of days.
Yep. Cool.
Yeah. Good question.
I don't really know anything about dry needling, but can you dive deeper into what you mean about pinning the sciatic as you were doing that?
Yeah, so we never needle a nerve directly. That can cause neuropraxia, especially if you stim it. You know when you hit a nerve, patients usually complain of like electricity, or some people call it like a sparkle, and what happens when you needle the nerve directly is you depolarize the entire nerve, and it feels like lightning has gone down their leg, like probably worse than their actual radiculopathy symptoms. So we want to avoid hitting it, obviously. When we just hit it with the needle initially and we get that, if we take the needle out, it goes away. But if we were to leave the needle and stim it, we would induce neuropraxia into that nerve. So pinning it means finding it anatomically. So through knowing where it should lay and then palpating, pinning it is putting a needle on either side, and then the current runs through it. So we get the effect of near direct stimulation of the nerve without sticking the needle into it and stimming it, which is incredibly painful to the patient, and then will actually cause some nerve death. So in the sciatic nerve, we start in the lumbar spine, we follow it through the glute and then down through the hamstring, and then we can try and follow it down through the calf, but it splits at that point. So we typically go to the top of the knee and leave it there, and then we run across the entire spine, the glute and the hamstring down to the back of the knee, and grab the nerve that way.
Cool, thank you.
Yep. You folks in New York need to get needling approved.
I'm getting out next year, don't worry.
So what's nice is you can get a similar effect there if you can't needle with cups. Same idea of cups on the low back, and then it'll be a little bit tough cups on the glute, but definitely as it comes back through the hamstring and goes into the calf, you can get cups on either side. And then what's actually nice about cups that you can't do with needles is you can move with the cups on. So you can have them doing prone press ups with the cups, tracing the nerve. You can have them doing hamstring curls, or even have them seated and doing like a slump slider progression with the cups on. So you can get a similar effect with some needling techniques with cups, just depending on anatomy.
So when you're throwing cups there, you're on either side, not over top. I've done it over the top, or where I think is over the top.
And I've done it over the top too. I mean, that's another benefit is you're not going to cause neuropraxia with a cup. So you can go right over the top. You can trace it, slide up and down it, or you can get the vacuum sealed ones and go on either side.
I haven't tried either side.
They're basically on top of each other, just trying to grab the whole part of the nerve going up. You tend to see cratering with this more than other stuff.
Along the nerve.
Yep, along the nerve, you'll tend to see more cratering than you will just on over top of a muscle.
Mm-hmm.
Okay, cool. If we have no other questions, I'm going to throw this recording in the ICE students page and on the Facebook event page, and then follow, if you haven't yet, in the ICE students page, the event page for this month's case study, because after tomorrow's visit, I'm going to write up what was hopefully his last visit and kind of keep you all informed of how it went. Hopefully it goes how we want it to. Cool. Thanks, everybody. We'll see you all in January. Hope you have a fantastic holiday season. Merry Christmas. Happy New Year. So awesome to have you guys hang out with us all the time. So I hope you have a great holiday season with your family. And if I don't see you before then, I'll catch you all in January. See y'all.
See ya.
Yeah, Tommy.